Hi everybody, welcome to AARC's Big Ideas Theater. I'm your host, Ed Hyland. Joining me now is Rich Callett, an expert on ventilator-assisted pneumonia, or VAP. Rich, thank you so much for coming by and joining us.
It's an honor to be here, so thank you for having me.
Let's talk a little bit about the difference between VAP and VAE.
Well, VAP traditionally is a very hard thing to diagnose, and there was a controversy as we shifted towards trying to improve patient outcomes that they thought it was totally preventable. This created a great commotion up around 2012. And the Centers for Disease Control and the Critical Care Collaborative were asked to come up with a new definition that would help us benchmark these things. So they came up with what's known as ventilator-associated events, and it's kind of a nesting of events that would help narrow in on who actually had, well, you could probably call a hospital-acquired condition. So what it is that a three-tiered nested process whereby you take someone who's been on a mechanical ventilator for at least 48 hours, who's either steady or improving, and then suddenly sometime after 48 hours their respiratory status begins to decline. And it's very reasonable. The decline would have to be an increase in the minimal PEEP level by 3 centimeters that's sustained for 48 hours, or an increase in FiO2 of 0.2, so let's say from 40 to 60% oxygen, that had to be sustained for at least 48 hours. So that's what's known as a VAC, or ventilator-associated condition, and it is probably a good marker for someone that seemed to be okay but then deteriorated after a couple of days of ventilation. Now, when that was associated, or is associated with overt signs of infection, such as fever, increased white blood cell count, that becomes what's known as an IVAC, or infection-related ventilator-associated condition. So the combination of Tier 1 and Tier 2 is what we call a ventilator-associated event. And that is what is going to be used eventually for benchmarking hospitals for what they consider possibly, for lack of a better term, medical errors or problems in care. Now, from that, they go into a third category, which is possible or probable ventilator-associated pneumonia, or VAP, which depends upon the degree of sophistication in sampling the lower respiratory tract for bacteria and the type of analysis they do of bacteria. That is not going to be used for benchmarking hospitals or reimbursement. In fact, it's interesting, since they've done this came out in 2013, we're at 2017, they still haven't figured out how they're going to use this. So it's very wise. They're kind of sitting back, we're gathering more data, but probably at some point ventilator-associated conditions or infection-related ones are probably going to be used for benchmarking hospitals.
You're getting into it, so let's drill down a little bit further and talk a little bit about the interesting developments in diagnosing VAP.
Yeah. This year, when I reviewed the literature for a talk I'm giving at the conference, there is a new diagnostic technique that's being looked at for ventilator-associated pneumonia, which is looking at exhaled gas samples for what's called volatile organic compounds, or VOCs, which I named it VOCs. What this is, kind of some background, anything that metabolizes, bacteria, humans, mammals, everything produces organic compounds, which, because they're volatile, they quickly go to a gaseous stage. So we can exhale these and they can be measured. Now, a few years ago, the group that published the paper this year had done some preliminary work and found that no matter how small the amount of pathogens in the lower respiratory tract, they produced what we could probably call a footprint. So when they measured this, about 150 VOCs, or volatile organic compounds, are exhaled by us. About 11 of them were tied to bacteria. And they either increased or decreased the footprint. And this was, again, something that could be looked at as probably one of the best ways to diagnose pneumonia. So this is probably something we're going to be looking at in the future. The problem right now is that it requires mass spectrometry and gas chromatography, which is not something that's readily available at the bedside, but with technological advances in miniaturization, it's possible for practitioners who are early on in their career, in their mid-career, the next 10 to 15 years, this is probably going to be something that we'll see commonly at the bedside. And the reason I say that is they're using this technology in observing COPD, asthma, and ARDS. So I think it has an incredible future, and I think this is a huge opportunity for respiratory care practitioners going in the future. It's a fascinating field.
You talked about the diagnosing side of it. Let's talk a little bit about the preventing side of VAP. Are there some steps, in your opinion, that can be taken?
Yeah, this is probably the most interesting aspect of all of this. I talked about the controversies around 2012. They talked about VAP being entirely preventable, and insurance companies were starting to say we're not going to, reimburse this, and Centers for Medicaid and Medicaid were basically saying the same thing. When we really drilled down to this, if you look at all the preventative therapies, they reduce the incidence of VAP by about 50%. And even what we call the mother of all VAP preventative measures, which is selective digestive decontamination, which is essentially sterilizing the aerodigestive tract with topical antibiotics, IV antibiotics. That, which is really intense therapy, only reduces the incidence of VAP by 50%. So VAP is basically related to the microaspiration of secretions. No matter what we do with our tube designs, which we've made incredible progress, they're not perfect. So drilling down more into this, the real issue, there's like early ventilator-associated pneumonia and late ventilator-associated pneumonia. Early ventilator-associated pneumonia within the first 4 days, most of that probably isn't VAP. It's probably the evolution of underlying disease or aspiration that occurs when someone's in respiratory distress or gets intubated, so before we actually put a tube down. What is probably the most effective therapy is getting patients off the ventilator quickly. Late onset VAP, which is predominantly gram-negative bacteria, has the highest level of morbidity. That's what we're really concerned with. And the highest daily hazard ratios for that are days 6 to 10. So if we can get patients, or the majority of our patients, off the ventilator earlier on, say day 4, maybe even less, we're probably going to substantially cut down on the incidence of VAP. And the problem has been, historically, is that we've basically been too conservative in our weaning practices. Over 70% of patients have no problem coming off the ventilator. And if you do things, if you standardize your practice, where weaning is done by spontaneous breathing trials, which means if you can breathe with little or no support for 2 hours, there's no airway issues, you pull the tube, and that's generally very successful. If you check and you take off sedation, what they call daily sedation interruptions or vacations, or you do targeted light sedation, keep people on the lighter side, these things all in combination reduce the duration of mechanical ventilation by about 1.5 to 2, maybe 3 days. In our institution, having done this since 2007, we've reduced the average days of mechanical ventilation from 6 to 4 approximately. And in ours, we're going to publish this in the next month or so in respiratory care. In ARDS, which is particularly difficult, we've reduced the median days of mechanical ventilation by 5. And even patients that had been dependent on the ventilator for 4 or 5 weeks before they met weaning criteria, they passed a 2-hour spontaneous breathing trial in 1 or 2 attempts. So the news is the most effective thing are the simple things, spontaneous breathing trials, daily sedation interruptions. By all means, we should be using the VAP bundle of standard things of raising the head of the bed, chlorhexidine, oral care, all these things are important. The most important thing is getting patients off the ventilator as soon as we can.
Fascinating insights. Rich Callett, thank you so much for joining us, enlightening us about VAP and VAE, and we'll look forward to the research as well.
Okay, thank you very much for having me.
And thanks so much for joining us. This is the Big Ideas Theater, sponsored by Draeger.